Hello, I'm Dr. Mark Mandel, and I'm going to be giving a lecture today on treatment of injured upper extremities. Most of you who are listening to the lecture have already received a YouTube presentation on the general treatment of upper extremity injuries, and today I'm going to focus on apportionment and other such issues. And as you know, uh, or may not know, I'm board certified in three different specialties: general surgery, plastic surgery, hand surgery. I've performed over 18,000 operations as a surgeon, and I've been the agreed medical examiner on over 10,000 cases. Today, I'm going to focus on soft tissue injuries. Those, of course, include muscles, ligaments, tendons, nerves, bone, vessels, and skin. I'm not going to talk about fractures. Most of these injuries occur from blunt trauma, crush, contusions, abrasions. I'm also going to explain the difference between a sprain and strain, tendonitis and bursitis, which is sometimes misunderstood. Hand injuries occur for about 10% of all the visits to the emergency room. Contusions and crush injuries are the most common. People get kicked, fall, struck, the hand gets caught in a car door. Patients all present with the same symptoms: pain, swelling, bruising, stiffness, and loss of function. The general treatment guidelines is using the acronym RICE: rest, ice, compression, and elevation, which is exactly what my grandmother told me many, many years ago. If you have an injury, keep it elevated, ice it down, and don't use it. Uh, Reading numerous reports from industrial clinics, they always say sprain, strain, tendonitis, overuse. Well, there's a difference between those conditions. A sprain means that there's a twist torque injury, and the ligament which holds two bones together is damaged. They come in all degrees of separation. Some of them are microscopic, meaning there's fiber damage, can't really see anything. Partial tear is grade 2, and if there's a complete tear, there's usually gross instability. We're talking about the wrist. A strain, on the other hand, means that the attachment of the muscle or the tendon to the bone is damaged. So these patients actually have muscle spasm, weakness, swelling, cramps, and inflammation. So a sprain between ligaments, a strain is actually the attachment of the muscle and tendon to the bone. So lateral epicondylitis, for instance, is a strain. There's no tendinitis in lateral epicondylitis. Tendinitis is can occur either acutely or due to overuse. Tendinitis means the synovial lining around the tendon is swollen, and when that occurs, the tendons don't glide, and that, of course, equals pain. ITIS on the end of anything means swelling or inflammation. General treatment for tendinitis: put it to rest, activity modification. Anti-inflammatory medications relieve pain but are not going to cure tendinitis. Steroid injections, immobilization, and a splint. Bursitis, on the other hand, or bursa, is actually a potential space. It's usually between muscle groups. And if it becomes filled with fluid or inflamed, it becomes bursitis. A bursa usually allows muscles to slide over one another. They're usually found around big joints, hip, shoulder, elbow. Inflammation, of course, causes pain, swelling, decreased motion, localized tenderness. The treatment is activity modification, anti-inflammatory medicines, corticosteroids, drainage, occasionally necessary, surgery, proverbial court of last resort. So generally speaking, most soft tissue injuries can be treated conservatively using the acronym RICE. They're exceedingly common, and the treatment, again, is summarized by the acronym RICE. Now let's look at some specific forms of tendinitis. The most common ones: wrist tendinitis. The wrist is moved by tendons On the dorsal aspect of the wrist, they kind of extend your wrist. Those are extensors, palmar flexors. Any of these multiple tendons, which number about a dozen and a half, can be inflamed, irritated. That results in tendon or dysfunction. Now, if you look at a tendon, surrounding the tendon is the synovium. The synovium looks like the emperor's new clothes. It's barely perceptible. It looks like a shiny cover, but if it becomes inflamed, you can see the tendon doesn't increase. The synovium increases in size. The function of the synovium is to lubricate the tendon. So what happens is the tendons don't glide smoothly through the various bullies. Because if you look at your own hand, for instance, when you cup your hand, the tendons do not bowstring across the palm. The reason is they go through a series of pulleys. Inflammation causes the synovium to swell, so it's called tendinitis. Actually, it's tenosynovitis, results in pain and dysfunction. And at the back of the wrist, the tendons are held down by a dorsal retinaculum, and there are six separate compartments through which they uh, glide. Any of these can be involved in swelling. The most common, of course, is the Quervain's tendinitis, first dorsal compartment. So if you look at your own hand, you can see when you abduct and extend your thumb, you can see there's the abductor and the extensor and the snuff box in the middle where the people used to snort items. And I think sometimes they still snort items. Intersection syndrome means the second compartment is involved. An extensor tendon ulnaris is the sixth dorsal compartment, and that's actually the second most common form of tendinitis. Tendinitis problems are caused by strains, Swiss torque injuries, overuse, repetitive motion, contusions, and of course, postpartum. Uh, Mothers often develop the veins from holding their children close to their breast. Exercise, of course, can cause it on a non-industrial basis, and then we have the hodgepodge of unknown causes of tendinitis. But we do know tendinitis is more common in diabetics, people with rheumatoid arthritis, infection, lateral epicondylitis, more common in females and men, more common over the age of 50, people with, so I'm going to sit up straight now, poor posture, and smokers. Symptoms are the same: pain increasing with motion, swelling, weakness, and in the wrist, you might hear wrist noise, a grating feeling as the tendons rub against the overlying compartment structures. The classical article was written by Dr. McAuliffe, Journal of Hand Surgery. And this is for every type of tendinitis from the forearm down to the fingertips. Rest, non-steroidal anti-inflammatory agents, steroid injections, immobilization, and of course our acronym RICE. So who is Dr. de Quervain? We see it all the time. Fritz was actually a surgeon in Switzerland. He was a thyroid expert. He co-developed an operating table, but he noticed that the women that climbed the floors often developed a problem associated with their thumb, so he called it washerwoman's tendinitis. Now, forever associated with Dr. de Quervain is, of course, Dr. Finkelstein. He was a general surgeon in Chicago. I want to let you know that in the 1930s, there were only about half a dozen different boards. Before that, Dr. Finkelstein, I'm sure, did everything from general surgery to orthopedic surgery to major trauma. So when you graduated from medical school in the 1920s or earlier, you were either a surgeon or a physician. Well, he noted that if the patient grasps their thumb and turns it in a ulnar deviation, that will cause a lot of pain. So when examining someone who is suspected to have de Quervain's, we do the Finkelstein test last. Otherwise, we lose veins cooperation. So what occurs is the abductor pollicis, the extensor pollicis, traverse the first dorsal retinaculum. Swelling of the lining causes the tunnel to narrow and causing pain. So here we have a picture of a hand, and here's the abductor to the thumb, and here's the extensor to the thumb. And the surgery is to cut the first dorsal compartment. The general treatment was pointed out by Dr. Tom many years ago, put it to rest, splint. So you can see the theme here, most tendinitis and upper extremity injuries, put it to rest, medical treatment guidelines. The reason for pointing this out is when the patients go to the industrial clinic, they're almost always sent to therapy. There's really no indication these patients need therapy. They need a steroid injection and a splint and job modification. And if treated conservatively, 70 to 80% of patients do not require surgery. Now, what about the 20 to 30% that need surgery? Well, the success rate is 90%. So if you put together the 90% success rate for 30% and the 100% for the others, you have an overall success rate for treatment of decurvents of about 95%. What are the problems? Well, on the back of the wrist, there are many smaller tendons. So sometimes if you release the main compartment, there may be other compartments that are unreleased. The most common problem is injury to the superficial radial nerve, which is a small nerve that is right adjacent to the tendon. And if that is caught in scar tissue or damage, it causes fairly significant pain, like, oh, I can't stand to have my shirt sleeve rub against my arm. Stiffness and tendon subluxation. What happens is if you release the compartment, when you turn your thumb back and forth like this, I'm going to sit further back so we get a better view. Back and forth like this, it pops back and forth over the distal end of the radius, and that can be annoying, very difficult to fix. Now, intersection syndrome means that the second dorsal compartment, which is right next to that, will become inflamed. Now, this causes a lot more swelling because in an intersection syndrome, in addition to the tendon, the muscles also tend to swell. So much more swelling intersection syndrome. Well, who gets it? Well, not only in work, but pretty common in athletes, especially rowers, weightlifters, tennis players. The second most common form is extensor carpi ulnaris tendinitis, and that's on the little finger side. The usual common injury etiology is a twist torque injury. Now, right next to that tendon, I'm going to roll my shirt sleeve up here. Right next to that tendon is a very small nerve called the dorsal sensory branch of the ulnar nerve. So these patients often have tingling and numbness in the back of the little and ring fingers. Now, in treating ECU tendinitis, it should be known that the floor of the tendon sheath stabilizes the triangular fibrocartilage complex, and sometimes it's difficult to differentiate between is this problem tendinitis or is this problem a TFCC tear. So the way that I tend to do it is I like to inject the wrist with local anesthetic, and if the pain goes away and the wrist is anesthetized, then you know the problem is inside the wrist. If it doesn't go away, it's probably outside the wrist. I think that's a lot better than ordering first an MRI that is a 3-month delay, then you order an arthrogram, and you still don't have the answer. Steroid injections are beneficial both for problems inside and outside the wrist. Now, what are the complications of surgery? Well, hopefully you can avoid surgery for ECU tendinitis, but the dorsal ulnar sensory nerve can be injured. Here, the tendon tends to, when you move your wrist, the tendon tends to snap back and forth over the distal end of the ulnar, and as opposed to the radial decurvents, sometimes the tendon ends up being frayed. You lose motion loss. So to conclude, the wrist tendinitis is swelling of the synovium surrounding the tendons. Successful conservative care, 70% of the time, breast splints, steroids, activity modification, surgery successful, 10% of the time. The complication rate for surgery is around 10%. So in terms of tendinitis of the wrist, it's always best to avoid surgery if possible, or it's always best to avoid surgery, period, if possible. Trigger fingers are quite common, also known as stenosing tenosynovitis. And here you can see that the tendons go through a series of pulleys, which is why when you bend your fingers, again, the tendons do not bowstring because they go through a series of six little pulleys. So the most common site of the trap bend is what's called the A1 pulley, which is basically at the distal palmar crease. And what happens if this tendon catches, sooner or later, due to irritability, the patient is going to develop a nodule or swelling. So what happens is inflammation narrows the space within the sheath that surrounds the tendon, and the tendon has difficulty sliding. And like all conditions, they come in various degrees of severity. And what happens is from repetitive use, there's actually a swelling and a lump that catches on the pulley system. And if it's severe, the fingers end up in a flexed position and they're very difficult to open. So here again, the problem is usually inflammation at the A1 pulley. This is where they tend to stick, although rarely they can occur at other levels at all as well. Who's at risk? Well, again, uh, women are more common than men, more common in the 40s and 50s, very common in patients who have a prior hand injury, and they're quite common in people whose jobs require a lot of repetitive gripping. But who else is at risk? Because not every injury is work related. Well, diabetics have a high incidence, rheumatoid arthritis not quite as high. It's been reported in gout amyloidosis, but relatively low, moderate in thyroid disease, very high in patients who have an associated carpal tunnel, and very high in people who have Dupuytren's. Dupuytren's, I might add, is a 100% non-industrial condition, not caused nor aggravated by one's industrial exposure. The patients start off having some stiffness, usually in the morning, then they develop a popping, clicking sensation, the nodule develops, and then the finger tends to lock in a bent position. It can affect not only one but multiple digits, and in diabetics, it's often bilateral. Treatment, same treatment. Steroid injections decrease swelling, effective 40 to 50 to 70% first injection, but with every subsequent injection, decreasing efficiency, and I would not inject any site more than 3 times with steroids because steroids indiscriminately destroy tissue and you run the risk of rupturing the tendon. And I might add, patient is diabetic, the steroid injections are not quite as effective. So what do you do if the patient is a problem? Well, if you're skilled and there's like a single trigger finger that's not super severe, it could be treated percutaneously. In the office, put a little local anesthetic in, you have a sharp needle, you come in and you kind of like flick the tendon sheath open. But generally speaking, I would do this kind of surgery under local anesthesia in an operating room or under general anesthesia. Now, a very interesting article came out by Dr. Schultz. When do you use steroids? Well, they did a very extensive study. They said, well, if the triggering isn't too bad, mild conservative treatment is necessary. But if the patient has constant locking, multiple digits are affected, it's literally a waste of time and money to go to a steroid injection. So these patients, we're talking about severe locking like this, those patients go directly to surgery. Uh, Conservative treatment then is put it to rest, avoid repetitive gripping tools, and some people find a splint at night. Now, I want to let you know about non-steroidal anti-inflammatory agents. They're not going to decrease the swelling. They actually decrease the pain. Otherwise, they're ineffectual. If you want to reduce the swelling, you need to inject it with a steroid. Now, diabetes has to be considered, but this is not across the board, meaning the person who is pre-diabetic or diabetic for a month or two, very mild diabetes, is usually not a factor. But patients who are long-standing diabetics, people whose HbA1c levels are elevated, people who have had concomitant carpal tunnel, or have a very unusual entity called arthropathy or stiff hand syndrome, they have a very, very high incidence of tenosynotic problems. And this was pointed out by Vanny and associates, and they noted that trigger fingers were associated with elevated HbA1c levels. What is the incidence? Grandizio showed 2012 in his study that diabetics have a 8 to 10% incidence of triggers compared with 4%. And these are all patients that have had a carpal tunnel release. In conclusion, for trigger fingers, general population, 2 to 3%, a lot of variability in the literature, diabetics around 10%. So I want to point out that in the workers' compensation realm, if the patient is tenosynosis, is diabetic, rheumatoid arthritis, apportionment is almost always necessary. And moving up the arm, we have carpal tunnel. Now, carpal tunnel is not a tendonitis problem, which is why people who undergo surgery and have all the synovium removed, it's literally a waste of time, money, and also causes more scarring because carpal tunnel is a pressure phenomenon. If you look at your own hand, I mean, look at the back of the hand. I mean, there's some skin there, but it's pretty solid bone. But on the palmar surface, we have this thick ligament between the two muscle masses. And through that go the median nerve and all the tendons that move your flex your fingers. So carpal tunnel is a pressure problem. And if you look at the anatomy, you can see the very specific uh, sensory loss, thumb index long, and the radial half of the ring finger. The ulnar half of the little finger is supplied by the ulnar nerve. And this ligament is very thick, which is why when you bang your hand on a table, it really doesn't hurt because the nerve is under a very thick protective cover. Surgery is basically cut the transverse carpal ligaments. So on a transection, you can see here are the bones, and here's the ligament on top. So all these structures go through, and here we have our uh, median nerve. Now, carpal tunnel develops slowly, although on rare occasions it can follow a specific injury, such as a fresh injury to the hand or a displaced fracture, which compromises the carpal canal. So the patient starts a new job and they say, well, I have tingling and numbness 4 days after they commence at job duties. Uh, it's the prior employer's fault. And if the nerve conduction study is abnormal, it usually takes about six, sometimes 12 months for a nerve conduction study to convert from normal to abnormal. So we're really dealing with carpal tunnel as a continual trauma claim, a series of microtraumatic events that alters tissue homeostasis, which means that a series of repetitive activities causes the tissues to swell. And after a while, Mother Nature can't clear the swelling. So the typical story is patient works, Friday they're worse, they go home Saturday and Sunday, much better. Monday they come back to work, they're better. But what happens is over a period of weeks or even years, the body can't cope with this anymore, and the patient presents with uh, symptoms. And the symptoms are tingling and numbness and night pain. Epidemiologically, about 3 to 5%, again, depending on who's read, will develop carpal tunnel in a lifetime. Females, usually felt to be due to the smaller carpal canal size, have a higher incidence. The tingling and numbness is the median nerve distribution. Patients, in severe cases only, have weakness and clumsiness. Weakness is not a presenting problem in carpal tunnel. If you look at tables 16, 15, uh, on page 492, you can see the median nerve is mostly sensory, it's just a little bit motor. Classically, it's tingling and numbness and night pain. If the patient has clumsiness and weakness, you don't really need a nerve study. Just look at their hand because those patients are going to have severe thenar atrophy. So the test we do, of course, the Phalen's maneuver. Now that test has to become positive for within 30 seconds. Manual compression, Durkin test, increases the pressure, causes symptoms. Tinel sign, I might add, is notoriously inaccurate at the wrist level. Nerve conduction studies unnecessary in the workers' compensation realm, although an article was just published in the Journal of Hand Surgery, which indicates In the private sector, a lot of people don't even do a nerve conduction study. They go strictly on the patient's clinical presentation. Why does a nerve conduction study become abnormal? Because surrounding the nerve is a special fat called myelin that is actually compressed. What happens is that the nerve impulse, as it goes from point A to point B, goes through this compressed area, and there's a delay. So the median nerve of the wrist has both sensory and motor components, and those are altered due to what's called focal demyelinization. So here's a nerve conduction study. Doesn't make any difference if you're thin or fat or short or tall. The nerve study is accurate because the nerve study, it depends upon going from point A to point B. It doesn't really make any difference about the girth of the arm or the patient's height. Now, a nerve conduction study is really needed, but really only in severe cases do you need an EMG. I mean, I would say 95% of the nerves EMGs that I see are absolutely normal or they're overinterpreted by the whoever is doing the study. What do we need an EMG for? Well, you want to make sure we're not missing another diagnosis. In other words, is this carpal tunnel, or does the patient have a polyneuropathy? Does it have a plexopathy? Or is a problem coming from the neck in the form of a cervical radiculopathy? In the past 20 years, ultrasound has become quite common. It's actually quite sensitive. And in some rare instances, an MRI is needed, but usually you do an MRI to make sure you're not missing some sort of a tumor mass in the carpal canal. Differential diagnosis is therefore, is it the carpal tunnel or does the patient have a cervical radiculopathy? Do we have a pronator syndrome? Pronator syndrome means the median nerve is caught in the forearm. Do they have a brachial plexopathy or do they have a non-industrial condition? Motor neuron disease, do they have a stroke? They have a compartment syndrome. Compartment syndrome means, for instance, in the forearm, uh, there's too much pressure because the overlying fascial lining is unyielding and there's too much pressure, and that will shut off the blood supply and also squeeze the nerves. Rather amazingly, carpal tunnel was not even a known entity to the very end of the 1930s. Then World War II came along, so not much was done in the civilian population. George Phelan at the Cleveland Clinic wrote a paper in 1950 in which he described the entity, and now there are about 1 million new cases a year in the United States. Now, how do we get carpal tunnel in the workplace? Well, vibratory tools, assembly line workers, people who do repetitive gripping, flexions, extending. And when I first started doing carpal tunnels, and I've done 2,000 carpal tunnel releases, uh, almost every grocery checker had carpal tunnel because they used to flip back and forth, flex and extend over the scanner. Now, if you go to the supermarket, they kind of glide the items so they have a neutral wrist position. And the question is it the keyboard, is it the mouse? And there's a high incidence of carpal tunnel in people who work in environments in which you go back and forth between hot and cold. But also, there are non industrial factors, old fracture, arthritis, more common in women than men, smaller carpal canal size, and also in pregnancy, many women will develop tingling and numbness. But usually, if they have that, when they deliver the child, they tend to diurese, get rid of all that extra fluid in the body. The carpal tunnel goes away. But multiparous women have a fairly significant incidence, and the most common cause of idiopathic carpal tunnel is in postmenopausal women due to changes in the hormone flow. So we also, in addition to that, we have diabetes. They feel that severe diabetics actually have damage to the nerve itself, but also diabetes alters the microcirculation, so the blood supply to the nerve is altered. High incidence of rheumatoid arthritis because it makes the synovial lining swell, causing pressure, and an increased incidence in obesity. And the hypothesis here is people who are obese have the conduction of the nerve altered. And in addition, Arimidex, which is used for Post-surgical care, patients with breast carcinoma have a high incidence, hypothyroidism, multiparity usually manifesting itself in life. You know, some families just have a high incidence of carpal tunnel. Hey, my grandfather had carpal tunnel, my dad had carpal tunnel, my sister has carpal tunnel. So in some instances, it's genetic. Now, the treatment is change the workstation. Non-steroidal anti-inflammatories do not alter the basic problem. They only provide relief. About 20% of people on long-term non-steroidals will develop some gastric irritability. So my recommendation is stop the non-steroidal. Treat the underlying condition, whether it's thyroid, diabetes, or autoimmune. Night splints are useful in mild to moderate cases. And in patients who are electronegative, should be noted about 10% of patients have a positive nerve study but don't have carpal tunnel, and 10% of patients have a negative nerve conduction study of carpal tunnel. So what we do is we take some steroid and it has to be mixed with local anesthetic. We inject it into the carpal canal. The cortisone takes down the pressure. The patient states, wow, my hand feels great for about 4 or 5 days, a week or two, and then it's back to where it was. So if you inject someone with to do a provocative test, you better talk to that patient within a week. Because if the patient comes back in a month, they say, my hand is just the same. So you don't know if the test was useful. The point is, we don't like to operate on electronegative patients, but if the provocative test is positive, these patients do well with surgery. Now, can you treat carpal tunnel in different methods? Yes, countless things have been tried. Ultrasound, no use. Ice, good for acute pain only, low lay level. Laser, no treatment, no benefit. Acupuncture, classical study done by four very famous uh, disciplines in different schools, Chinese, Korean, and Japanese, pointed out acupuncture is really of no value for carpal tunnel. Acupuncture is a form of biofeedback. It's good for certain things, myofascial neck pain, but not for carpal tunnel. And the reason I point it out is I see every patient being sent by the industrial clinics for acupuncture. Vitamin B6, mega doses, chiropractic adjustments, magnets, and preoperative gabapentinoids, no value at all. Surgery. Patient doesn't respond to conservative care, they need surgery, open technique, mini open technique, endoscopic, they all work about the same. 80 to 90% of patients who have surgery should say the tingling and numbness and the night pain are much better in a matter of days. Now, they're still going to have incisional pain. In other words, they're going to have pain from the incision, but the hallmarks of carpal tunnel disappear. If they're complaining about tingling and numbness and night pain a month after the surgical procedure, that surgery probably was not successful. And of course, there are factors that reduce success: alcohol abuse, smokers, fully controlled metabolic or inflammatory disorders. And of course, you can do inadequate release. Uh, Patients can develop infection. 2000 carpal tunnels. I had one infection, but it was not due to the surgery. It was actually the patient had sinusitis, and the infection from the sinuses uh, went through the bloodstream, infected the hand, but as soon as the patient was put on antibiotics, it disappeared. The biggest problem here is injury to the palmocutaneous nerve. If you look at your own hand, the palmocutaneous nerve takes off from the main nerve about, since we're in the metric system now, 5 centimeters proximal to the wrist crease, and it supplies the thenar eminence. So if this little nerve is damaged, every time, whoa, I put my hand down, that is really uncomfortable. And if the discomfort is significant, the patient is complaining about basically of causalgia, somatic local pain. That's now called complex regional pain syndrome too, because a group of treaters and scholars got together in Budapest and they came up with a criteria to define pain perception problems. Now that is different than complex regional pain syndrome 1, also known as RSD and 20 other names, and that is global pain. So complex pain 2 is local pain Complex 1 is global pain. Now, how do you treat complex pain 2? Because a lot of the patients that have complex pain 2 are erroneously diagnosed as complex regional pain syndrome 1, and they get sent to pain management and do stellate block, stellate block, stellate block, and they're no better. Complex pain 2 is treated locally. What you do is you inject, you find out the most sensitive area. That's where that little nerve is caught, and you inject that area with cortisone and local anesthetic. If cortisone decreases scar tissue, may release that little nerve from the scar. You can repeat it 2 times. I wouldn't repeat it a third time. I would reopen the wound, and then I would take that little nerve. I mean, I did take that little nerve because I've done this procedure 20 times and bury it into the depths of the arm. And what happens is the little sensory nerve becomes a motor nerve. And the success rate is about 75, 80%. Now, in contrast, complex regional pain syndrome 1, also known as RSD and countless other uh, names, this should be treated if as soon as it is suspected. It doesn't mean sending the patient to pain management. Before there were pain management doctors, and don't forget that they've only been around for 20, 25 years. They're mostly anesthesiologists who know how to give injections. We surgeons treated patients with all of these problems and successfully. The patient needs aggressive therapy. I don't mean twice a week for 2 weeks. I mean 5 times a week for maybe 6 to 8 weeks. And a lot of times, the aggressive therapy, you can break the pain cycle. People who treat a lot of fractures noted that pain problems after treatment of the fracture can be treated with megadose vitamin C. We all remember Linus Pauling, or at least some of us do, who won the Nobel Prize, and he felt vitamin C cured everything, but it does appear empirically to play a role in complex pain 1. And then, of course, if the patient doesn't improve, they're going to need blocks, either local or distal. And if the patient really is developing RSD or complex 1, I would recommend they go to a multidisciplinary group, which are present in all the major medical centers, such as Cedars-Sinai, USC, Loma Linda. And I personally like Dr. Ferranti at UCLA. I felt he does a great job. And some of these patients will eventually need a spinal cord stimulator. And in the past, they used to be really bulky, but now they're very, very sophisticated. But I would say a spinal cord stimulator, order of last resort. But what are the factors for carpal tunnel? Well, Dr. Stallings noted that obese patients, now we're talking with BMIs over 30, have about twice the incidence of carpal tunnel. Dr. Palumbo noted in patients who had undergone thyroidectomy for various conditions, had Hashimoto's, Graves' disease, they had about 3 to 4 times the incidence of carpal tunnel, even if their uh, thyroid was replaced with levothyroxine or Synthroid. And they felt that even if corrected, the natural hypo, if the natural thyroid state is altered, these patients somehow or other have the electrical threshold lowered and have a high incidence of carpal tunnel. Diabetes, of course, is the thing we all worry about in terms of apportionment, because Brown showed that the incidence of carpal tunnel and diabetes, depending upon which author is read, was 15 to 33% compared with 2 to 5% in the general population. Now, the key factors here are how long has the patient been diabetic, and basically how well is the diabetes controlled. And don't forget also, a lot of these diabetic patients are also overweight. And if they have a polyneuropathy, there's an exceedingly high incidence of carpal tunnel. Gahagan, uh, 2 decades ago, noted in his hands these different risk factors, but again, you can see diabetes is the highest. Recently, several interesting articles were published. The first one said by Dr. Yao that you better have the patient's HbA1c less than 7 if you're doing elective surgery, otherwise high incidence of infection and poor wound healing. And then, contrary to general thought prior to 2018, in which we felt, well, we can't inject any steroids into a diabetic patient, it'll cause their blood glucose to go off the wall. And a very extensive study found that a single or even two injections of steroid are not going to elevate the patient's blood glucose level. Now, what is interesting about diabetics is if you do a carpal tunnel release in a diabetic, they do just as well as people without the metabolic disorder, but they have a very high recurrence rate. And that's due to alteration of the different tissues caused by the diabetes because it alters the microcirculation and healing. Now, what is a diabetic polyneuropathy? Well, this is a stocking glove pattern of numbness that's due to axonal neuropathic process, which means that the myelin layer around the nerves is diffusely compressed, as well as alteration in the microcirculation to the nerves. So patients usually present to the lower extremities first because the nerves are much longer than the upper extremities. And why don't you know that eventually long-standing diabetics, 30 to 50% are going to develop a diabetic polyneuropathy. And it should be noted that diabetic polyneuropathy has neither been caused nor aggravated by one's industrial exposure. So Perkins looked at all these factors, reference population, 2% carpal tunnel, patients diabetic, no polyneuropathy, 14% incidence of carpal tunnel, 30% incidence of carpal tunnel patients with a polyneuropathy. So in conclusion, while carpal tunnel can be reversed by activity modification and use of night splints, if the carpal tunnel is recalcitrant and conservative care surgery is necessary, and the success rate should be 90%. Now, a lot of people complain about, I can't open a twist drop jar, can't do a push-up. That's part and parcel of the operation because when you transect the transverse carpal ligament, you lose some stability. Well, that's the trade-off. No more tingling and numbness and night pain. Okay, get a rubber gripper to open your jar. Carpal tunnel is more common in patients with metabolic disorders, arthritis, prior trauma, women and older patients. So apportionment may be necessary in these groups. But I might add, simply being diabetic and overweight doesn't mean apportionment is necessary, which is why you should go to an agreed medical examiner because most of the QME reports that I read really have no scientific merit. Well, moving up the arm, we have cubital tunnel. So what is that? Cubital tunnel is a stretch injury of the ulnar nerve that traverses the medial aspect of the elbow. So if you touch your medial epicondyle, if you go towards the inside and if you roll it, you can actually feel the ulnar nerve, feels like a cord. And if that nerve is involved, uh, it causes tingling and numbness and weakness. Now, if you look at table 1615 again, you can see the ulnar nerve distribution is mostly motor and a little bit sensory. So patients with cubital tunnel often have a loss of strength, whereas patients with carpal tunnel, it's unusual to have a grip loss greater than 20% unless the carpal tunnel is severe. So here we have the different nerves. Here's the median supplying here, the ulnar nerve. Of course, the radial nerve supplies the back of the hand. Radial nerve compressions are relatively uncommon. Some people feel that radial nerve releases are ineffectual and the results aren't good. Now, why do you get cubital tunnel? Well, it usually comes from repetitive flexion extending. Of course, you can have a direct blow to the elbow, or you can have lax ligaments causing the nerve to flux back and forth out of place. I want to point that out because, again, in the industrial clinics, the patient presents with an elbow problem. The first thing they do is send it to therapy. That's actually doing the test that we use to determine if the patient has carpal tunnel, cubital tunnel. So clinical presentation, tingling and numbness, little ring fingers, grip loss, and clumsiness. Clumsiness because the ulnar nerve supplies a lot of the little intrinsics. So I have the patient keep their fingers apart, and then you tell them, keep them apart. If they have cubital tunnel, a lot of severe, the fingers usually collapse, or you can just have them snap their fingers because the ulnar nerve will cause that hand to be clumsy and painful. So here's the ulnar nerve. It's interesting that in contrast to the Tinel sign at the wrist, the Tinel sign at the elbow appears to be more accurate. Here we have the distribution of the ulnar nerve. This is the palmar surface. Here's the dorsal surface. Physical examination, patients present with some strength loss, pinching and grasping, a loss of dexterity. Sensory loss, they have a positive Tinel sign. And if you have them flexion and extend their elbow 10 times, usually say the tingling and numbness increase. So any job that causes repetitive, prolonged activities for the elbow to be flexed can cause this problem. People have associated medial epicondylitis and bursitis, but of course they can have prior trauma or bone spurs that would be non-industrial. The initial treatment is modify activities, ergonomic workstation, don't lean on your elbow. And in the past, we used to use a rigid splint, but they were so uncomfortable, no one wore them. But you can have the patient wrap a towel around, but for $50, you can buy a pillow splint, which is much more effective. Treatment, non-steroidal anti-inflammatories for pain relief. Here, I'd be a little cautious about injecting steroids around the elbow because the skin is quite thin, and a lot of times there's irritability in the nerve. Pillow splint, and here some tendon, special tendon gliding exercises may be beneficial. Nerve conduction study is necessary, but it should be noted it is not as accurate at the elbow level, at the wrist level. The nerve study is 90% accurate for carpal tunnel. It's only about 75 to 80% accurate for the ulnar nerve. So we do have electronegative patients. We need to do an x-ray, make sure there's not a fracture bone spur. We want to make sure the patient does have a metabolic disorder. Now, patients should be treated initially unless their problem is super severe with a pillow splint. That needs to be worn for months. You know, wearing the splint for 3, 4 days or a week is not going to reverse carpal tunnel. But if you let the elbow rest at night for several months, a lot of times these cases will heal on their own. But if you do not, there are about 25 operations described, but now most of the studies indicate a simple release. But if necessary, do a transposition, epicondylectomy, or put the nerve either within or underneath the muscle. Surgical problems include an inaccurate release, or you can damage the medial or superficial antebrachiocutaneous nerve, which is like the elbow equivalent to the palmar cutaneous nerve. So this is a little nerve that originates about 5 to 6 centimeters above the medial epicondyle, and it supplies sensation over the medial aspect of the elbow. So that nerve is damaged to various degrees about 20% of the time. And most of the time it's just an annoyance, but sometimes it'd be very, very, very uncomfortable. And it has to be treated either with cortisone injections into the painful side or even a release of the nerve. Well, moving up, we have an unusual entity, poorly understood, called thoracic outlet syndrome. It's interesting that before Dr. Phelan and others described carpal tunnel, people were having thoracic outlet surgery done for what we now know as carpal tunnel. Well, thoracic outlet means the nerves and the blood vessels are caught somewhere between your neck and your armpit, or more accurately, between the clavicle and the first rib. So patients present with pain, numbness, and vascular changes. And thoracic outlet had a lot of names before the surgeon at the Mayo Clinic decided to give it a overall name, but before it's called a scalenus anticus syndrome, hyperabduction syndrome, costoglobicula, and multiple others. But basically what happens is you can see here the nerves coming out of the neck, and they have to go between these two structures, and there are various muscle components that can compress it. The scalene muscles, labius muscle, and many others. Who gets thoracic outlet? Well, traumatically, I'm riding on my motorcycle and someone knocks me off my bike. tossed over the handlebars, have a combination of a whiplash injury and considerable swelling. That's traumatic thoracic outlet. But you can get it with sports, weightlifters, swimmers, people who use their arms repetitively. Painters, hairstylists can develop thoracic outlet. And of course, if you gain a lot of weight, you can also get it. And of course, people who have an extra rib of a high incidence, and people with poor posture, which is what we see. Here's an anecdote. So, many years ago, I had two patients with thoracic outlet who had memory hyperplasia, and I convinced Fremont uh, Insurance, not the reason why they went out of business, that if I did a breast reduction, uh, the pain would disappear as opposed to sending him to UCLA and having a rib removed. And indeed, that surgery was successful because when we're gigantic mass here, we're kind of leaning like this. So what do we see now? Well, in the old days, when I was in training before electric cars, uh, I walk into the surgical office and the secretaries would sitting there in perfect posture. I might add, immaculately groomed all the time, and they'd be typing on their selectric IBM typewriter. We rarely saw thoracic outlet. We rarely even saw carpal tunnel. But now, especially when working at home, we tend to relax. And when you're doing this, you're actually doing a costoclavicular maneuver. You're compressing the nerves. So what do we see? Or what kind of thoracic outlet is? Well, 95% of the cases are disputed or neurogenic. 3 to 5% could be venous, and 1 to 2% are arterial. In neurogenic, that's what we see in workers' comp. Really non-specific complaints, take like a numbness, pain, can't grip, easy fatigability. The most common etiology is due to poor posture. In venous thoracic outlet, easy to diagnose. The patient's arm is swollen and blue. They have prominent veins over their shoulder and neck, and that's due to a clot in the major veins. And these patients have arm fatigability. Now, rarely this can be caused in a work-related basis if someone does very sudden forceful activity and develops a thrombus in one of the major veins. I would say that is a rarity. So venous thoracic outlet, reportable in the medical literature on an industrial basis. Arterial thoracic outlet, easy to diagnose. The patient's hand is ice cold, there's not enough blood, pale, weak. These are usually due to an embolism or an aneurysm of the subclavian artery. Cause here is trauma, acute trauma. What are the risk factors in neurogenic? Well, women 3 times more common than men, usually occurs 20 to 50 age group. The treatment for neurogenic or disputed thoracic outlet is therapy, changes the workstation. In the past, some of the advocates were injecting never-ending Botox. I want to let you know a vial of Botox costs about $600. And many instances they will use 2 vials in one visit. Well, Botox doesn't last forever. It has to be repeated every 3 to 6 months. Surgery is the last resort in work-related disputed neurogenic thoracic outlet. I might add there's a high recurrence rate, either due to recurrent scarring at the operative site or misdiagnosis. The same procedure, venous thoracic outlet, almost always non-industrial, resect the scalene for rib removal, blood thinners, thrombolysis. A lot of these patients need what is called a balloon angioplasty. Arterial, the same thing, same muscle resection, blood thinners. And here, often arterial segment needs to be replaced. Diagnosis is difficult. All these provocative tests had to, which involve looking with your arm elevated, looking this way, doing your Roos test, shrugging your shoulders. 90% of people have one of those tests positive. You need an X-ray to make sure the patient does not have a cervical rib. A duplex study ultrasound is useful to determine if there's any vascular blockage. Scalene blockade, uh, brachial plexus blockade is beneficial. Brachial plexus MRI. I want to let you know that I've hardly ever seen a brachial plexus MRI that was not abnormal. So here are the various tests. Our favorite is what Bruce, but I want to let you know that I have a positive Bruce test in 20 seconds, but I do not have thoracic outlet. So peak, looking at the experience 4 years ago as to the long-term results following this kind of surgery, he said thoracic outlet, especially disputed or neurogenic thoracic outlet, is poorly understood condition. The diagnosis is debatable because there are no objective, well-defined diagnostic criteria. Indeed, it is in the rare patient that has a positive nerve conduction study. The patient might have a positive nerve study, but they have carpal tunnel and cubital tunnel. They don't have thoracic outlet. So diagnosing disputed thoracic outlet is a challenging task due to the variability, presenting symptoms, and the lack of sensitive and specific diagnostic tests. So in conclusion, for thoracic outlet, the results for treatment are disappointing compared with those for traumatic type of thoracic outlet. Patient selection is critical. Conservative care should be exhausted before operating upon disputed thoracic outlet in the workers' compensation realm. One last topic is what is the rotator cuff? Well, the rotator cuff is a group of muscles and tendons that surround the shoulder joint, keeping the head of the humerus within the fossa. The shoulder is basically a lax or unprotected joint. So instability is inherently present in the shoulder joint, just like it is in the thumb and in your hip. And the reason is the joint capsule is twice the area of the humeral head, allowing for large joint and protected motion. So we're dealing with a ball and socket joint with a shallow glenoid, sacrificing stability for mobility. So we're looking, which is why we can move our arm in every direction. So we're looking like the head of the humerus is basically a golf ball sitting on a tee. So here's the glenoid fossa, the scapula. Or you can see here, here's the head of the humerus. Here are the four muscles. Now, almost always, the supraspinatus is the most commonly affected muscle. And sometimes when they talk about a complete tear, they're actually not talking about a complete tear of wall fall cuff. They're actually talking about a tear of the supraspinatus. Now, why does the supraspinatus tear? Because it's the smallest muscle, has the poorest blood supply. So here, looking at the shoulder, we can see the four rotator cuff muscles and the anatomy. Here's the deltoid muscle. And here we have all our bursa, which can become inflamed. Here's the long head of the biceps, which often is injured in labral defects. Dr. Budoff, who is the guru that we hand surgeons use as our favorite orthopedic shoulder expert, pointed out that almost all rotator cuff injuries occur on a continual trauma basis, but it can occur acutely. So when we see a patient with what's called a tear, a lot of times there are significant degenerative changes, and then the last effort was like the straw that broke the camel's back. So who will get an acute tear? Well, with major macro trauma, you can see a complete tear, mostly in younger patients, but patients that are middle age or older, it's always almost micro trauma or things that occur over a period of time that was the problem. Now, Dr. Cotting, in reviewing rotator cuff injuries, know there's a whole spectrum from tendinopathy to partial tears to complete tears. But he pointed out that 9.7% of patients, I might add, who is asymptomatic have tears seen on the rotator cuff. And he found out that 60% of patients in their 80s have either partial or complete tears of the rotator cuff. How do you treat rotator cuff tears? Medical treatment guidelines strengthen the scapulothoracic. Stabilizers improve motion, cortisone injections, jump modification. And what you proceed with next is the level of pain, the results from treatment, and then you need an MRI. But you have to correlate any diagnostic study with the patient's clinical presentation because, as you just pointed out, 9.7% of people in their 20s have changes in their rotator cuff. And the question is, hey, did the injury occur at work or did it occur at play? And that was pointed out by Tunis, Journal of Shoulder Elbow Surgery, out of the Harvard Mass General Group. Posey, Journal of Shoulder Elbow Surgery, said, hey, is this problem old or new? Because in his study, 50% of patients over 65 have either complete or partial rotator cuff tears. And Dr. Yamamoto, in a study of 1,366 shoulders in the general population, great age group, showed that 20% of those patients had full thickness tears. He found that the trauma, dominance, age were the biggest risk factors. Milgram, in an ultrasound study, noted that 50% of patients in their seventh decade had tears in their dominant right arm and 80% in their eighth decade. So Tempelhoff concluded that in his study entitled Age-Repeated Tears, we're talking about asymptomatic shoulders, that tears must be regarded as normal degenerative attrition, not necessarily causing pain and functional impairment, which means you can have a complete tear of a rotator cuff and be asymptomatic. So the risk factors in determining whether this is work-related and what should be done is, what is the patient's age? Are they smokers? That accelerates degenerative changes. Is there a family history? Some family histories, everyone in the family has rotator cuff tears. Poor posture has been associated with it. And for some reason, people with significantly elevated lipid levels. So my point here is, in performing any type of a diagnostic study, be it an MRI, a nerve conduction study, unless that study correlates with the patient's clinical presentation, there is no impairment nor any need for treatment. The reason for pointing this out is in AME, I've seen numerous cases in which patients have undergone ulnar shortening procedures because it seems to be a little bit longer than it should be, whereas on the other side it's just as long, and those patients are in help. People have undergone carpal tunnel with no history of tingling and night pain, but the nerve study is abnormal. So, if there is no impairment, you're not going to improve the patient. So unless the clinical study correlates with the patient's presentation, there's no need for treatment. And as surgeons, we operate upon human beings, not an abnormal study. I want to point out the complication rate of the workers' compensation realm for any type of an upper extremity surgery, be it shoulder, elbow, hand, or wrist, is much higher than in the private population, and the patients take much longer to recover. So my personal philosophy is treat the injured worker as you would like a member of your family treated, and I like the members of my family. And I learned that from my father, who was a family physician, and I'd see him go out at night with his little black bag and get paid $5 many years ago. Now he'd be a concierge physician, but times were different. All of us are here to help the injured worker. Thank you so much for your attention.